now invite, okay, okay, I now invite Dr. Vineet Joshi to speak on cataract surgery in ocular surface disease and PUK. Dr. Vineet.
Hello. Okay. Thank you, Dr. Swarup, for this opportunity. And actually, this was supposed to be presented by Dr. Swapna, and I'm thankful for her. She has given us her talk. I'll be talking on her behalf on how to approach cataract surgery in dry eyes and ocular surface diseases. So, this is gaining quite a popularity these days, only because now we are paying a lot of attention to ocular surface and right from mild to moderate and severe forms of disease. So normally a stable ocular surface would be a non-keratinized squamous epithelium, and basically all the units of corneal conjunctival epithelium working fine. But on day-to-day basis, our surface is constantly at war with environmental, toxic, and inflammatory agents, and also in some cases infective and traumatic scenarios. What happens in a surface is there is a thin homeostasis between the epithelium, the tear film, and also the subepithelial, superficial stromal kind of inflammatory reaction. And the lid margin and the tear film play a big role in actually stimulating these responses. And all of this show is guided by the nervous system within the cornea at different levels. What happens in a surface failure? The routine squamous so the normal epithelium gets converted to a keratinized epithelium, and there is also a limbal stem cell deficiency. In such advanced cases of ocular surface disease, you are going to encounter scarring, a lot of vascularization, sometimes symbiophron formation, and any surgical intervention in this case or in this scenario is hostile. So, being cataract being the most common surgery performed, there have to be certain areas which need to be tackled carefully. Now, if we see retrospectively amongst the cataract surgeries done, many studies have found out that 63% of patients actually had T-but less than 5 seconds, and there was a huge load of underdiagnosed ocular surface dysfunction, and most of them related to MGD, but these can become pathological if not paid attention to. So also, on the other hand, what a cataract surgery does is that it can reduce your tear film meniscus height at the T-bud time, and also it increases the fluorescence staining. So there is a damage occurring from both the ends. So you need to be watchful of the patient's pre-existing signs and understand what your surgery is going to incite to. So what are the main inciting agents? Increased inflammatory mediators, post-op inflammation, toxicity from your drops, especially containing benzalkonium chloride, and damage to corneal nerves from limbal incisions. So these are the inciting agents from surgery per se. That is why it is very important to identify certain signs preoperatively, like for example lid margin thickening, clogging of meibomian glands. If you're seeing congestion of the tarsal conjunctiva, if you're seeing some form of fibrosis over there, and then this important examination of lids should be followed by examination of conjunctiva, cornea, and the limbal side, vascularization, faint scarring, and overall what is the staining pattern of the cornea and conjunctiva. So this case is actually having ocular surface disease. Is one example that you should keep in mind before planning any cataract surgery. So usually these cases which are long term, having ocular surface disease, probably very severe form of dry eyes, will have some form of corneal thinning, and these invite a lot of problems. And if there is an abnormal surface, if it stains bad, it is going to be a big problem for doing a biometry to actually get good keratometry readings, and also to plan for a good IOL power. How do you work up for these cases? So basically start by doing your routine autoimmune workup. If you're having a patient with severe dry eye disease, then this is the panel that you can refer to, and actually keep in mind that these are the patients who are going to worsen after any form of surgeries. So they actually need preoperatively some form of systemic therapy with topical and sometimes even oral steroids. Otherwise these incisions don't heal well, and there is a lot of problem postoperatively. So there can be different causes of cataract in ocular surface disease. It can be age related, which is most common, but prolonged use of topical steroids, ongoing surface inflammation, and sometimes the chemical injuries. If the chemical seeps into the anterior chamber, it can cause presenile cataracts as well. So, what are the challenges you're going to face? Most prominently, inflammations, sometimes cicatrization changes, lid abnormalities, very commonly compromised media clarity, and post-operatively difficult wound construction. Intraoperatively, you're going to face a problem of how to choose the correct IOL power, and there are ways how you can tackle it. I'll just show them to you in the next slide. But there are certain dictums that if you can follow, like you should need to control the conjunctival inflammation if it is active preoperatively. Maybe give a course of topical steroids for at least 3 to 4 weeks. Prefer perivalvular blocks. Avoid doing a topical surgery in these cases. And to improve the corneal clarity, if you're not confident with phaco, you can always resort to ECC or SICS. And temporal approaches increase the exposure, but many times you will have to release the symblepharon and the fornical shortenings. Also, liberal use of viscoelastic devices. I would say it's very. I mandatorily use trypan blue. It really helps to get a fine contrast while doing the surgery to find out the capsular rhexis edges. If you have an endo illuminator, then that's fantastic. It is a lifesaver, especially when you are actually trying to do a case with a very bad opaque cornea, and preferably in a retro illumination mode, so that once the opacity, the main chunk of nucleus is out, you will be able to do a successful cortex wash with the help of the retro illumination. So just skip the post-operative management part. Only two important points here. You have to continue the steroids for a longer time along with lubricants and also some steroid sparing agents which are immunomodulatory. Now in IOL power calculation, most of the times there will be steep corneas due to corneal thinning. Better to do oculizer before, or any topography maps to get in oculizer. You have these EK maps, which actually EKR maps between the central 3 mm 4.5 mm, that can help you get a good K value. But if there is dense scarring, then there will be flattening, then it's better to go for standard values. But if the surface is very bad and it is opaque, you can always resort to leaving the patient aphakic, because pros lenses in these patients, especially patients after Steven Johnson syndrome, give very good visual acuity. Even if you leave the patient aphakic, pros lenses can cover up for that. So this was one of the studies which was done in ocular cicatricial pemphigoid, the cataracts, which we did and followed up, and then they really do improve. The cataract is one of the significant areas where we can change something and give a better visual impact for these patients. Like you can see, at least 2 lines in 6 of the 9 patients improved in cases which are unforgiving. So I just mentioned about pros. I would just now show you certain surgical steps which are very important. I thank Dr. Pradnya for giving some of these videos. So here, as I mentioned to you, it's very important, use trypan blue. As you can see, the corneas are very opaque, and you can see that faint retro illumination glow behind. And with the help of trypan blue, you will be able to make out the edge that you're actually doing for capsular rhexis. So whichever way, even a slightest form amount of scarring, I think trypan blue is really useful. um, okay, this is the, yeah, the next one is where you can actually use retro illumination in, yeah. So if you have an assistant who can hold this in the right angle, You just need to tilt it maybe at an angle of 60 degrees, wherein you will be able to get that correct reflex. Or and once the aim is to just clear off the nucleus, because as soon as the nucleus is out, your retroillumination will help you guide the remaining cortical wash. So again, in these cases, doing a very good hydrodissection really helps, because that is going to help you in clearing of the cortex after you remove the nucleus. In some cases, you would actually need to release this symblepharon and increase the exposure, uh, so that you can actually place a speculum. And then it is wise to first examine which site is good to actually make an incision. Always examine. Sometimes these patients also have scleral thinning, as you can see here. That's why the surgeon has taken slightly posterior incision over here. And then once ECC or SICS is done, replace the area where you release the symblepharon with an AMG. So I would like to stop here, and maybe we can take some key points on discussion because these are very important regions. So I think the takeaway point would be examine the patient properly. If at all there is an active inflammation, delay the surgery. Please treat it appropriately with topical steroids until the surface stabilizes, because it is going to help you get a better biometry. And there is no harm in actually leaving the patient aphakic. The worst disaster that can happen in these cases is a nucleus drop. So all you have to make sure that the nucleus is out, and with the IOL, then you can decide based on how much thinning is there, how much opacity is there, whether you can place a correct powered IOL or you can leave it aphakic, because pros lenses in these patients really give very good visual outcomes. Thank you.
Thank you, Vineet, and for the lovely videos and lovely tips that you shared with the audience. If you have any questions, please note them down. We'll have adequate time to discuss them later on.
Hello.
I now invite
I have a
Dr.
question for him. In fact, I have a comment. In my opinion, many of the patients who have watering or this vague irritation after cataract surgery, if you look carefully, you'll often find that they have conjunctivochalasis. And if you identify it preoperatively, it's a very common thing actually, conjunctivochalasis, and we often don't pay attention to it. And if you can actually identify it when you're doing cataract surgery, all you need to do is either cauterize the conjunctiva or just snip the excessive conjunctiva and just reoppose it, and that often helps these patients
Yes.
quite a bit. In fact, many of them, you know that they're going to get watering after surgery if you don't address it, and sure enough they will get it. So I think that's something which all of us who are not cornea surgeons or anything, just routine cataract surgeons, just look carefully for folds of conjunctiva inferiorly or infranasally, because these will prevent proper spreading of the tear film, and it will cause spillage of tears usually from the lateral side of the eye.
I think that you have raised an excellent point. So this examination of conjunctiva and tear film, and especially the lids, is very important. I mean, I can give one example that one patient, we actually missed this, and we did an SICS in a total cataract, and till 5 6 days we had hypotony. We were not understanding what is going wrong, and then we thought of actually doing the systemic tests, and she came out to be positive with Sianka, and all the systemic, the worst that we could imagine was there, and we missed that. So we had to keep her on systemic steroids and keep her admitted for a month until the pressure actually built, because the wound they just don't heal well. So you have
Right.
to treat it like a complete ocular surface case and then take care of it. And so these clinical examinations are very